Hi everyone, my name is Saja, and today I'm going to be doing my anatomy presentation on Crohn's disease and ulcerative colitis. So what is ulcerative colitis and what is Crohn's disease? Ulcerative colitis is a chronic inflammatory disease that specifically targets the mucosal and submucosal layers of the large intestine. The disease always begins at the distal rectum and extends proximally in a continuous fashion, sometimes reaching the sigmoid colon, descending colon, transverse colon, and in more severe cases, the ascending colon. The inflammation is always continuous. There are no healthy segments between affected areas, and the inflammation is limited to the mucosa and submucosa. The muscularis propria and serosa are typically spared. The rectum is always involved in ulcerative colitis, which is a distinguishing feature from Crohn's disease. So Crohn's disease is a chronic relapsing inflammatory disorder that can affect any segment of the gastrointestinal tract from your oral cavity to the anal canal. However, it is most commonly involving the terminal ileum, which is the most distal segment of the small intestine, and the proximal colon. Crohn's is characterized by skip lesions, which are patches of inflamed tissue separated by normal healthy tissue. The inflammation is transmural, meaning it involves all layers, the mucosa, submucosa, muscularis propria, and serosa. The transmural inflammation can lead to fistula formation, which is abnormal connections to the adjacent organs, strictures, which is the narrowing of the lumen, and abscesses. And just to go over the normal structure, there's a lot of images here, but I just want to make sure that we understand everything so that we know which areas are affected by ulcerative colitis and Crohn's disease and how they can impact the body. So large intestine begins at the cecum, which is the right lower quadrant, and then continues to the ascending colon, the right lateral, the hepatic flare, which is the right upper quadrant, the transverse colon, which is superior and horizontal, the splenic flexure, which is the left upper quadrant, the descending colon, which is the left lateral, the sigmoid colon, which is the inferior and medial, the rectum, which is the most distal, and then the anal canal. Your small intestine ends with the terminal ileum, which connects to the cecum at the allocecal valve. And then looking at your wall structure, we have the 4 layers. First, we have the mucosa, which is the innermost with the epithelial cells, lamina propria, and muscularis mucosae. Then you have the submucosa, which is the connective tissue, blood vessels, nerves. And then we have the muscularis propria, which is circular and longitudinal muscle layers. And then we have the serosa, which is the outermost layer. More importantly, we also have the haustra, which is the saculations of the colon, giving it a segmented appearance. And then we also have the lumen, which is the central passageway for digested materials. And then here I just have an endoscopy of what a healthy colon looks like. So you can see that there's the smooth, glistening pink mucosae with regular, fine vascular patterns that are clearly visible. The haustra and the mucosal folds are distinct. Lumen is free of exudate or ulceration. And now for the structure with ulcerative colitis, or UC. So when you see the mucosae and submucosae of the rectum and colon become erythematous, ulcerated, and friable, the inflammation extends proximally from the distal rectum without skipping any segments. We have the loss of the haustra, which is the chronic inflammation that leads to a smooth lead pipe appearance on imaging, especially in the descending and sigmoid colon, as you can see here in the image on the bottom right. We have the crypt abscesses, which is the neutrophil infiltration of the crypts of the libercune in the mucosa. We also have pseudopolyps, which are islands of regenerating mucosae that protrude into the lumen. And severe cases of ulcerative colitis can cause toxic megacolon, which is this massive dilation often in the transverse or descending colon, and longstanding disease increases the risk of colorectal carcinoma, especially in your distal colon and rectum. And then here in this endoscopy, we can also see on the left, we have the score of 0, which is the normal colonic mucosae with clear vascular markings, no bleedings or erosions. And then as we progress to score 1 and 2, you see progressive loss of vascular pattern, the appearance of mucosal oozing, and then shallow, deeper ulcers. And as we reach score 3, the mucosae is profoundly disrupted, bleeding pools obscure the view, vascular architecture is gone, and deep ulcers penetrate the bowel wall. And now the structure with Crohn's disease. So Crohn's disease causes transmural inflammation, most commonly in the terminal ileum and right colon. There's skip lesions, which are patchy areas of inflammation with intervening normal mucosae. The cobblestone appearance, which is that deep linear ulcers and fissures intersect with the edematous mucosa. We have the thickened bowel wall due to chronic inflammation and fibrosis, especially in the distal ileum. We have the strictures, which is the narrowing of the lumen due to fibrosis, often in the terminal ileum or proximal colon. We also have the fistulas, which are abnormal connections that can form between the bowel and adjacent structures. For example, your bladder, skin, or other bowel loops that are often in the lateral or posterior aspects. We also have the creeping fat, which is this mesenteric fat that wraps around the inflamed bowel segment. We also have the granulomas, which is the non-caseating granulomas that can be seen on biopsies, especially in submucosae and muscularis propria. And then again, here's a side by side of all three. We have the healthy, and then we have ulcerative colitis, and then we have Crohn's disease. So within the endoscopies, again, we can see on the healthy side, smooth, glistening pink mucosa, no ulcerations, no pus, no nothing. And then through ulcerative colitis, we see the diffuse erythema and mucosal edema beginning in the rectum and then extending proximally. We see ulcers and areas of friability, pseudopolyps. We also see vascular markings are partly or completely obliterated, and there's some superficial oozing. In Crohn's disease, we see patchy, deep ulcerations, often with the cobblestone appearances of alternating raised mucosa and depressed ulcers. We see the transmural or full thickness involvement that can produce strictures, the narrowings, and fistula openings. And then we see that fat creep may be seen running along the serosal surface. Now, for diagnoses, it is important to note that the exact cause of ulcerative colitis and Crohn's disease is unknown, but both are believed to be triggered by a combination of genetic predisposition and environmental factors interacting with the immune systems. There's various ways to diagnose these, including endoscopies, biopsies, imaging, and lab tests. In endoscopies for ulcerative colitis, they typically look for continuous superficial ulceration from your rectum proximally. In Crohn's, they look for patchy deep ulcerations, often in the terminal ileum and proximal colon. For biopsies with ulcerative colitis, we look for mucosal and submucosal inflammation, crypt abscesses. In Crohn's, we look for transmural inflammation, granulomas, or fissures. In imaging, for UC, they look for that loss of the haustra, or that lead pipe colon. In Crohn's, they look for the string sign, which is the narrowed terminal ileum, the fistulas, or the abscesses. In lab tests, they typically look at elevated inflammatory markers, which are your CRP, ESR, or if you're anemic due to all that blood loss. It's also important to note that these are chronic conditions, so they cannot be cured, but there is various ways to treat them, such as steroids, medications, biologics, and in more severe cases, surgery. And that is my presentation. Thank you so much for listening.